Onc Live Insights is a video editorial program produced by Onc Live.
So let's talk a little bit more specifically about some of the common adverse events associated with regorafenib when you are able to institute that in the later line setting. What are the common AEs you see, and how do you manage that in combination or collaboration with your oncology nurse?
Sure. So the most common reaction is a hand-foot skin reaction, and once again, I start off at a lower dose to try to prevent that from developing as much as possible. And we just ask our patients to continue to communicate with us, make sure they let us know if they're having any of those side effects so we can address them early on before they get significantly worse. It is recommended that your liver function tests are tested, and so I test my patients every 2 weeks for the first month, and I do ask them to come in, even though one cycle is every 28 days, I ask them to come in basically after a 14-day interval just to make sure they're tolerating things well.
And what's the typical onset time for the AEs that present with regorafenib? How soon after administration do you start seeing effects?
The hand-foot skin reaction can occur fairly early on, I would say, but I really haven't had any significant additional toxicities. Obviously, I've seen some cases of thrombocytopenia with prolonged therapy, which would not be unusual, but I've really had no issues with increased liver function tests on any of my patients, unless it was due to disease.
So how about the frequency of dermatologic toxicities and fatigue? How often do you see those?
The fatigue has not been so much of an option, it hasn't been so much of an issue, sorry, as long as, once again, I've dosed the patient appropriately. And if they are that fatigued, I will give them a small break, let's say a few days, reevaluate them, and then maybe even cut it down further to 80 milligrams instead of the 120 milligrams to start.
So how about the role of the oncology nurse in managing these adverse events at an institution like MD Anderson? How is that handled?
Pivotal role. The clinic nurse, and if you have a mid-level provider, significant resource for the patient. We also have PharmDs at our institution, which really make a huge impact in our patient care. Everybody has a role involved in educating the patient, making sure that the patient can reach them, can communicate to them. Because with the use of an oral chemotherapy agent with some potential toxicities, obviously, that are not minimal sometimes, you have to make sure that the patient has access and can contact you and can explain what they're seeing. Because obviously, if they can't explain what's going on and you're not seeing them regularly, that obviously is quite a big issue that can be very detrimental to the patient's care.
Hi, my name is Jessica Mitchell. I'm one of the nurse practitioners at Mayo Clinic. I work exclusively with gastrointestinal malignancies. The role of the nurse in managing adverse effects of chemotherapy is critical and fundamental to the patient's safety and tolerance and ultimately response to chemotherapy. Creating a role where the patient feels comfortable with the nurse in calling with side effects and problems is fundamental to the patient's overall tolerance of the drugs. My role in the management of AEs at Mayo Clinic is, I would say, multifactorial. I typically will see the patient at the onset at their initial consultation with the oncologist, and that's where we describe initially the drugs and their side effects, and that is sometimes a scary time for patients because we try to give them a framework from where their treatment's going to go and also every side effect that they might experience. Most of the time when I see patients, they'll come back after the first couple weeks and say, the first time I saw you, you told me all these things were going to happen and none of them happened, or 3 of them happened. And I hope that that's what I hear more often than not, because that says to me that I'm doing what I should be doing in educating people on how to appropriately manage their symptoms and start to establish a relationship that we can work together to make sure that they tolerate the drugs, are safe, and get the best benefit. Oncology nurses are critical in management of early toxicities associated with regorafenib, particularly with cutaneous side effects. And I always tell patients, if you're unsure what's going on or if it's something that you need to stop your regorafenib for or get more attention or someone to see your side effects, then you need to call us. And so intensive phone management, even if you can't see the patient. But I think that ongoing assessment and fluid management of patients where they feel comfortable and safe with you is critical for patient safety again and overall tolerance of the drugs. And I actually think that's one of the major things that nurses do the best, is we love taking care of patients and being there for people when they need us the most, as do oncologists, but sometimes I think we're a bit more available, and especially with a drug like Regorafenib, that intensive upfront management will carry out and over for months for patients, and ultimately, again, they'll tolerate it better. Patient education is vital in the management of side effects associated with all chemotherapy drugs, in particular Regorafenib, because the side effects of Regorafenib happen so much earlier than what you see with other chemotherapy drugs. Some of the most common side effects I see with using Regorafenib or Starvarga include dermatological side effects. We have historically always known about hand-foot syndrome, which we see commonly with a drug called capecitabine. But hand-foot reaction syndrome with Regorafenib is definitely unique. This side effect from Regorafenib typically is asymmetrical. It happens at a much more rapid rate than we see with capecitabine. It happens primarily on pressure points and can be quite severe. So managing that proactively is critical for overall patient tolerance. Additionally, Regorafenib also has other specific side effects that you don't see as commonly with other drugs, such as elevated liver function tests, hypertension, and mucositis. Some of the less severe side effects we also see include diarrhea, fatigue, and anorexia, which I think share commonality with most chemotherapeutic drugs you use with patients with advanced colorectal cancer. The typical onset for adverse events seen with Regorafenib really happens in the first few weeks, and in particular the first 2 months. If patients can make it through those first 2 months, you really see a dramatic improvement in their side effects from month 3 and beyond. So that first few months, intensive patient counseling and education and communication is critical to the patient tolerating the drug over the long term and ultimately getting the best benefit. We typically schedule a follow-up visits for patients that are newly starting Regorafenib in the first 2 weeks. At that 2-week visit, we do a complete chemistry panel, which would include the liver function test that can be elevated, as well as checking their white blood cell, red blood cell, platelet count, creatinine. We also ask patients to intensively monitor their own side effects by keeping personal journals about their side effects, and we try to call within 7 days of starting the drugs just to make sure that they're tolerating the drugs. After the first 2 cycles, after the 2 weeks, we usually move out to monthly visits because patients do so much better and their side effects are so much more diminished. Our experience with grade 3 and 4 side effects from Regorafenib, fortunately, have been few. Where we really saw grade 3 side effects was during the initial studies that we were a part of in developing Regorafenib. Fortunately, at this institution, we never saw grade 4 side effects. Grade 3 adverse events from Regorafenib really were the severe hand-foot reaction syndrome that patients experienced, elevated liver function tests, hypertension, and mucositis. And I think that stems partially from dosing and inexperience with the drug. But now that we're so much more attuned to the side effects and how quickly they start, we're much better at controlling those side effects. So we really do not see grade 3 or 4 side effects as frequently as we initially did. Dermatological side effects from Regorafenib are quite common, and I think that they can be managed appropriately, if not completely avoided, significantly improved with proactive education and management of patients. Again, that goes back to creating a patient who is their own best advocate and knows their side effects, knows when to contact the medical professionals taking care of them, and knows what to do to help themselves. So it is very common that patients will experience redness, pain, and swelling on the pressure points of both their hands and their feet. Again, it can be asymmetrical. Also, mucositis is very common. So for hand-foot reaction syndrome that we see with Regorafenib, we ask patients to use a thick emollient cream on their hands and feet at least twice a day. Make sure that they remove all calluses on their feet. Wear very comfortable cotton socks that allow their feet to breathe, and good sturdy shoes that don't encourage blister formation. For mouth washing, good oral hygiene is critical. Washing their mouth, rinsing their mouth out with warm baking soda or saltwater solutions, or if the mucositis is more irritable, we can give prescription mouthwashes. I would say that fatigue is common to every chemotherapy agent, and I think that it's partially drug related, but also disease related and partially psychosocial as well. Patients undergoing treatment for cancer and advanced cancer is a very stressful time in their lives. It can cause a lot of anxiety and depression. Thinking about your own mortality can be very difficult to contemplate. And then when you have side effects from both the chemotherapy and the disease itself, you put all those together, it creates a significant amount of fatigue. So we would expect that in treating patients with metastatic disease. We manage that depending on its severity. Sometimes we give patients low-dose steroids to help with energy and appetite. Sometimes we use low-dose stimulants beyond steroids, such as Ritalin is commonly used. Thirdly, we always try to provide psychosocial support. Well, sometimes that means antidepressants, sometimes that means anti-anxieties, sometimes that means counseling, sometimes it means all of those things. But I think it's critical when you care for a patient that you make sure that you include that as your overall, part of your overall treatment plan, because you don't just treat the disease, you're treating the person and everything that entails.